Olá, bom dia, bem-vindos mais um Osteotalk, desta vez com o osteopata Christian Lunghi. É osteopata, é autor de vários artigos, escreveu um livro chamado 5 modelos osteopáticos, é membro da ROI, membro da ISO, está ativamente envolvido na osteopatia em Itália e é o nosso convidado de hoje, muito feliz por isso. Foi nosso convidado no ano passado pela Osteoform, numa formação que tem. Estes são alguns dos artigos científicos do Christian Lunghi e nos livros do Christian. E foi convidado o ano passado pela Osteoform numa formação chamada Cuidados Osteopáticos Adaptados à Prática Clínica, da filosofia à prática clínica. Christian Lunghi tem sido, como eu disse, bastante ativo e é um nome conhecido na osteopatia na Europa e na Itália. É docente também e ultimamente, há cerca de uns dias, em debate, num debate feito pela My Osteopathy, pelo COM, onde em resposta a um artigo também editorial no International Journal of Osteopathic Medicine, veio ao debate os chamados 5 modelos osteopáticos e o modelo biopsicossocial. Os 5 modelos osteopáticos incluem um modelo neurológico, psicossocial, biomecânico, metabólico, energético, respiratório e circulatório e a interpretação do paciente nestas componentes. Também um modelo biopsicossocial, que também tem sido posto em causa, em que olham para o paciente, mas é também uma forma e um modelo usado na osteopatia, do ponto de vista social, psicológico e biológico. Recentemente, em janeiro, houve uma carta ao editor que tem gerado algum entusiasmo e alguma discussão intelectual, porque mexe naquilo que é a nossa identidade e empurra um bocadinho as nossas crenças e a nossa forma de olhar o paciente e de olhar a profissão. Esta carta ao editor, chamada Models and Theoretical Frameworks for Osteopathic Care, uma carta ao editor do professor Dr. Jorge Esteves e colegas, que saiu em janeiro, então, no International Journal of Osteopathic Medicine. É uma carta ao editor bastante interessante, como eu disse, empurra um bocadinho a zona de conforto, obriga-nos a sair um bocadinho da zona de conforto e olhar para dentro. De resto, foi uma carta ao editor que foi respondida por várias pessoas, por vários autores, incluindo o Christian Lunghi, incluindo também a delegação do COM em Portugal. E é, no fundo, nesta base e neste contexto que houve uma conferência na passada sexta-feira, creio que foi na passada sexta-feira, em que o Christian Lunghi explorou e explicou e defendeu, no fundo, os 5 modelos osteopáticos, na medida em que estes 5 modelos osteopáticos tinha sido um ponto de crítica no artigo escrito pelo professor Dr. Jorge Esteves, em que fala dos 5 modelos osteopáticos, na abordagem dos 5 modelos osteopáticos, como estando no nível de evidência D, nos modelos em que tem apenas um consenso naquilo que são os especialistas da área. E, portanto, os níveis de evidência podem-se ver em Generalized Theory, uma teoria robusta, ou uma teoria exploratória, e modelos com suporte empírico. E neste artigo, então, no Models and Theoretical Frameworks for Osteopathic Care, os 5 modelos osteopáticos, é um dos modelos aprovados pelo benchmark da World Health Organization, vinha nesta carta ao editor, então, como um nível de evidência D. Isto, como é evidente, levou aqui a bastante debate e continua a levar a bastante debate, e é neste sentido que eu convidei também o Christian Lunghi para falarmos sobre então, os 5 modelos osteopáticos, o modelo biopsicossocial, porque em larga escala, pelo menos na Europa, é ensinado nas universidades e de alguma forma também apoiado por alguns osteopatas. A próxima Osteotalk vai ser já na próxima quarta-feira, com a delegação COM Portugal. Fiquem à espera, porque promete também ser bastante interessante, em que vamos ter como convidados o Alexandre Nunes, o Rui Santiago e o João Moita. Ok, vamos passar à conversa.
Bom dia.
Bom dia, bom dia. Let me just...
Good morning, everybody. Thank you for your invitation.
Thank you so much for accepting our invitation, and it's such a pleasure, always a pleasure to talk to you. So I just made an introduction of the context of our talk, and a very short introduction of your resume. And yeah, so I enjoyed reading your article very much. Your response to the editor, response to the letter of Professor Dr. Jorge Esteves. There was quite a few responses to that letter. If I remember, there's quite a few of us that had replied, and for sure it's food for thought and takes us out of our comfort zone and makes us have a discussion and just the discussion that happened within my osteopathy webinars, and you also present.
That was the idea, to share different point of view, to put that in the crowd, in the crowd of the community of practice, of osteopathic practice, just to collect also what the community of practice, what is the community of practice thinking about that, just to stimulate some responsiveness by our colleague, by the clinicians, not just the researcher. That's lots of work.
That was my first. Sorry.
Lots of work to do for the community of practice, I think, in my point of view.
I know we're such a young profession still. I mean, we're still palpating and still growing in terms of, I think, in terms of a solid identity and a solid theoretical base. So
probably in Italy we are moving on with the process of recognition. We had the law signed in 2018, but we are still in progress for the application of the law that was stopped now for the COVID time. But
I know what you're talking about. I was very much involved in the regulation of osteopathy since 2003. I was very much involved into that, and thank God we went through that, and we came out in a very good position, actually. So thank God. I understand what you're going through. Yeah. So I guess my first question, if you allowed me, just as an intro, would be, I mean, everyone agrees that we need a solid, robust scientific model, and that is very important and it's crucial for the identity of a profession. And we used to have, just like Professor Jorge Esteves mentioned in the article, in the letter, we used to have this banner, this flag, that we are a profession that looks at patient as a whole. It's patient-centered care, and you know, in the last years, other health professionals are also looking at the person and at the patient as a whole, and this patient-centered care, is not only an osteopathic care. Other health professionals are also looking at observing symptoms and diseases in a more, let's say, holistic approach. So, being that a very strong point of our identity, we start losing somehow, or questioning our uniqueness, let's say. And questioning our identity sometimes can be painful, can be challenging, because it kind of shakes our beliefs and shakes our solid ground.
Yeah.
But it's very necessary for the, I think, for the evolution of science and the consolidation of scientific based practice. So in the last years, the benchmark of World Health Organization considers, as you said, the 5 osteopathic models as part of the osteopathic training, and some countries in Europe adopted it, and some osteopaths also follow that conceptual and theoretical reasoning. But the problem is not all countries or not all osteopaths adopted it, and so it's not a widely accepted
Definitely not.
theory, so model. So my first question would be, what can we expect? What to expect from theoretical models to be widely accepted?
Well, um, first of all, thank you for the question, because it's, I think, the main topic of the debate. First of all, I want to say that the general aspect that represent the substrate of the debate is the scientific theoretical model that we have to decide to based on. And as Professor Estevez wrote, we supposed to be centered, to be focused on the person-centered theory. But in reality, we wrote that, but maybe we were not really focused on that in practice. Because, for instance, in my experience, in my training, I was taught more in terms of some pillars of osteopathic care developed in Europe that are described as the structural, the visceral, and the cranial pillars of osteopathic care. I was not really taught about osteopathic models. They were named in my training, and in reality, after the world benchmark in 2010, I have not seen a real change in the osteopathic curriculum. I have never seen in reality the structure function models into a curriculum. Just the first one, the first proposal I've read, where the 5 models are taught, is the Italian core competence proposal that was published in 2018 in the International Journal of Osteopathic Medicine. In my knowledge, I have seen the osteopathic structure function model into the American curriculum.
Yep.
And as you probably know, they were developed since 1970, thanks to a consensus between pedagogists, osteopathic teacher, and clinicians in 2 or 3 yearly meeting, and then they are presented in 1987 into the American curriculum. And the aim was to describe the distinctive way of osteopathic physicians to manage in practice the person-centered theory. And they move forward the idea of structure that change and modify function, biological function, into an interdependence between all the body framework and the body functions, including the psychosocial, the psychological reaction to the environment, the social environment, into that construct. And they speak more in terms of homeostatic, allostatic reaction, also psychological reaction, not just biological, to the environment. This, I don't know if it really represents our practice, but it's a proposal to drive the clinical reasoning, the osteopathic clinical reasoning. It's not a conceptual epistemological framework of osteopathy. The epistemological framework, the structure function model referred to, is the person-centered theory mixed up with the evidence-based medicine theory. So research finding and individual personal finding into the practitioner and patient relationship that could be represented maybe into a clinical reasoning focused on the structure function models. I don't know if it's the right answer, if it really represents our distinctive role, but that is the aim, to represent a distinctive role to answer to health needs and quality of the health services. Because if we don't have a clear distinctive role, also interprofessional, but in some aspects a distinctive role to answer to health needs and to improve the quality of health service, it's not about we don't have, or maybe we have, a theoretical framework. If we don't have a distinctive role, there's no profession. And not just for the politicians, also for science. So, well, I was asked to speak about the structure function model. Well, I'll do my best. Just trying to explain the origins and the evolution, and then my mind line. So the way I use in practice, I use that in practice, and I would say I find useful. It's a little bit difficult to explain, maybe in 1 hour or half an hour, because speaking about a clinical reasoning based on structure function model, it's the entire curriculum. So it's, for instance, another aspect, it's the way you use to do an interprofessional practice and a shared decision-making model, decision-making with the patient, but also with other professionals. So saying metabolic model integrated with neurologic model would say, in other terms, working together in a treatment program with a nutritionist, with a dietitian, and also with the neurologist to improve, with the aim to improve patient condition, working together. And it's in other terms, it's the way to use a language shared with our professional.
Yeah.
But maybe we have other models.
Yeah. Yeah, I mean, we were talking before recording this, and we share the same how do you say, the same mind line. I mean, I can see both sides, and as you were saying in the States, that this or not only in the States, but the introducing cognitive sciences and referring to allostasis and allostatic load. I'm having a guest next week, is an osteopath and is very much involved into allostasis, allostatic load, and what it does to the stress, what it does to the brain and to pain. And including this concepts and this new ideas of science and this new research is we can include that into our practice even, as you were saying. I guess lately with this pain sciences findings, the relation and the connection between structure and functional changes, it was questioned, because we find functional changes, we find changes in the function, alterations in the function, without having change.
I've lost you. I can't hear you. Sorry, Bruno.
And the touch, the effective touch, the placebo interoception, it shaped kind of our belief between structure and function are interdependent, because we're actually seeing that a dysfunctional area in our central nervous system, or in terms of pain or whatever it is, it doesn't have to be directly linked to a structural dysfunction or structural change. And I guess this is also what stirs a bit the beliefs in this model. And as Stilwell and Harman proposed this inactive view of pain, with the way pain is innate, emotive, embodied, and embedded. This pretty much involving the patient and the neurological mechanisms of the patient, and not directly related to a function or to a structure, structural changes. I guess this is one of the reasons why we're having this conversation. Wouldn't you agree?
Yeah. Well, I totally agree. I just I've lost, I don't know why, maybe the internet line, like 20 seconds of your question, but I think I agree. And
the connection is not great. Yeah, sorry.
Yeah, don't worry. Probably it's my line. You started the question speaking in terms of allostatic load, and to answer to speak with you about that question, I won't go back to the allostatic load model, because if we have a look at the description of the adaptation processes, thanks to the allostatic model, we can find that we have the homeostatic stability, the homeostatic shift to maintain, thanks to stability, the internal milieu. Then, when there is a challenge came from the outside or from the inside, you have to move, you have to change. And when you change, you increase the self-regulative responsiveness, and the self-regulative responsiveness are musculoskeletal movement and tissue physiological remodeling, also neurological reaction, intrinsic connectivity network, and all the sensorial reaction, interoceptive, exteroceptive, and proprioceptive. You have also metabolic reaction. You have circulatory reaction. You have the breathing pattern that will change, and you have psychological, behavioral change to adapt to the environment challenge. This condition need some primary mediators, as all of you know. Some primary mediators, cytokines, hormones, all of that, to favor that adaptation process. And in cases when the challenges, when the environment demand is a little bit heavy, a little bit hard, the responsiveness need to be more powerful. And when you go ahead with the adaptation allostatic processes, you go into something that is called by different authors as a secondary outcome. So in other terms, the cumulative effect of the primary mediators, so hormones and cytokines, change the activity of the mentioned systems, also eliciting, also favoring secondary outcome in tissues. The secondary outcome in tissues are called strain, but are called elastic deformation strain. And the elastic deformation strain are reversible. Then you have a condition that if the challenge insists on you, you go into tertiary effect, that is the frank disease. So pathology, anatomopathological changes. So if we speak in terms of structural changes and we think about tertiary effect, so plastic deformation strain, not reversible. So the pain science says to us, well, we can have a chronic pain. We can have pain without tertiary effect, without structural changes, without anatomopathological changes, without plastic deformation in tissue. But if we have a look at the allostatic model, we found some changes that can elicit symptoms and are not anatomopathological changes, are reversible changes. And in my speculation, well, sorry about that, but in my speculation, when we speak in terms of somatic changes, somatic dysfunction, I don't know how we want to call that. But when we speak about somatic dysfunction, we are speaking about elastic deformation, reversible deformation. So maybe we have to try to have a look at that changes in another way, because if we want to try, we try to look at that, trying to find some anatomopathological changes, we are not going to find anything. For instance, this morning, early in this morning, after my gym, I was reading a paper, a recent paper. It's not an osteopathic paper. It's about Stecco. Antonio is the last author, and they use a particular setting of the magnetic resonance, and they found in the region, for instance, in that cases, in the region of the symptom, of the pain symptom, nociceptive pain symptom, they found far in a remote area from the area of the symptom, but in the same region, they found some water changes, some aggregation of hyaluronates with water, that maybe this could represent an aspect of secondary outcomes of elastic deformation, reversible deformation. I don't know if it's the right method to search in that. Or, for instance, I was thinking, I've read a paper about the TACAN channels, some channels involved in nociceptive pain. And for some authors, the TACAN channels are the mechanical aspects of the chronic pain, of the nociceptive pain. So I don't know if it's right basic science to explain that, but there are some observation of tissue mechanics changes, but there are not plastic changes. There are not anatomopathological changes. I don't know if it's the right answer of your question, but I think it's
perfect.
a different point of view.
Yeah. I'm sorry if the connection is not so great, but my question was answered in with your reply right now. I was questioning exactly what you answered, so it was perfect. I mean, it's the the complexity of a human being and a human organism and human mind is huge. So finding the right tools and the right approaches and the right it's just very challenging to study, if maybe not impossible to study, at least for now, to study all the mechanisms that play within a manual intervention or osteopathic intervention. I mean, I myself, I teach in my classes. I also teach in the university. I teach the 5 osteopathic models. I teach the biopsychological psychosocial model. I mainly focus on the 5 osteopathic models because it gives it gives this overall look and perspective, but also a very deep perspective into the patient and how all the systems interplay, and they can be involved in the symptoms experienced by the patient, pain or non-pain related, any alteration in neuroimmune system related to stress, or a neuroendocrine system, or vascular or respiratory, that can actually make huge changes in the metabolism and the metabolic actions, causing acidosis, alkalosis, and that interferes with so many different things. So I think looking into the 5 osteopathic models, it gives this wide spectrum, explains this wide spectrum of symptoms and signs and conditions. And even doctors are now talking about something called multi-systemic diseases, where they include Lyme disease, fibromyalgia, and they're in medicine. They're also, I've been watching some congresses and seminars, and the neurologists come together with rheumatologists, with internal medicines. They're looking into the microbiome. They're looking into neuroimmunology, and they're coming together to explain this very complex diseases. And my question, just I'm sorry, I'm taking too long. My question is, um, if we include pain sciences as we do in the 5 osteopathic models, and if we include the recent studies in fascia neurobiology, if we transfer evidence from other practices, from other professions to ours, and isn't the 5 osteopathic model a model with some empirical support and explanatory theory as well, and not just as not just the consensual model between experts as proposed? Also, isn't this all this integration and transfer evidence and all this, everything that we've been talking about can be included in this 5 osteopathic model?
Well,
doesn't that automatically, yeah?
I think in your question, there's a roadmap. You clarified a roadmap. So, in my personal point of view, the person-centered theory is expressed into a clinical reasoning based on 5 osteopathic models, and for that we have to maybe just update the concept with for instance, as you mentioned, allostatic model that could permit us, allow us to rely psychical behavior and biological behavior. Also, life tensegrity or other aspects related to more mainstream, related to tissue mechanics. So the new biomechanics we can use to inform the concept. Also, of course, pain science and neuroscience in general, we have to. Also, the science of placebo, that is also part of the neuroscience, and all the specific aspects, including, for instance, the right communication, the right communication skills to use with patient. We can easily update the concept. Well, if we want also to change the name of the framework, the name of the model, and to use just one, for me, it's not a problem. It's okay. If we want, say, just biopsychosocial, as some of us suggest, for me, it's okay. But I mean, if it's not just psychosocial, if the word bio means something, maybe not just biomechanic in old way of thinking, but we have to balance the focus of our practice, in my point of view, because balancing allow us to be osteopath in my point of view, and to be osteopath also in an interprofessional way of thinking and of practicing, and allow us also to implement science in practice, because thinking in a structure function model way of thinking, for instance, the structure function model drive you to program a treatment plan centered to the needs of the person, in terms of the decision are not coming from what an osteopath think on what an osteopath palpate, but the thinking and the intuition and the palpation are processed and based on patient responsiveness. So in other terms, you have to evaluate the responsiveness of the patient, you have to evaluate an emergent pattern, and then you program the part of the treatment that we can call tailored treatment. Behind it, you can also put what we call symptom-based approach. In that approach, you can put your self-reflection on your literature research, trying to find the most powerful, the most effective approaches that you find in literature for similar clinical contexts. So you can mix up into a treatment program some aspects from evidence-based and some other aspects from that are emergent from patient need. And if you use a theoretical model to do that, for instance, evidence-based practice model, and in other terms, to balance a person-centered model, in my point of view, you well expressed by the 5 osteopathic models, or by a renovated biopsychosocial model where the part bio is strong enough as the psychosocial. So because it has to be described also the hands-on part, because, well, we are hands-on. I used to do some, for instance, some active patient approaches that, to explain to our colleague, sometimes also in books I called exercise, but, well, the exercise I use are like the technique I use. It comes from my osteopathic evaluation, my, let me say, osteopathic diagnosis. And to do that, I can do that into a relationship like the technique. In the osteopathic technique, I do a little bit more and ask the patient to participate in the active approach or exercise. He does or she does a little bit more with my help, with my hand put it on, just to aware is conscious.
For sure. I mean, I was talking to Francesco Contiero, the last Osteotalk, and this active approach and active participation of the patient is very important, because one, we're very active beings, so we need movement, and the cells need movement, and the body needs movement, and it makes sense not to treat someone only in a passive way, but also in an active way. And also the assisted action, assisted active movement actually gives the patient the reassurance, the confidence to actually perform the movement that maybe is afraid of doing the movement. So it's very important. But also we need to move. We need to. This is very important. The theoretical framework, very solid and based framework, because we need to also move from just the palpation diagnostics. It's not complete, because it can be intuitive bias, or and we should move on to a more analytic and not so intuitive, not so depending on us, and finding this framework with which robust, solid ground provides us also to move away, but not to solely depend on palpation, which can be very biased, as you said. Just to finish, do you think, if you allow me just to finish one last question, I'm sorry to take if I'm taking too much of your time. Do you think there's a clinician, there's an academia linguistics that is difficult to convey the message, or difficult to interpret, or there's a linguistic barrier between academia world and clinicians, and so there's a sort of a gap there that we're not meeting sometimes into that expectation?
Unfortunately, I think we still have a gap. This is one of the main points. I think you focused one of the right point. Definitely, I think we have that gap. I really don't know how to manage. I really don't know, because in reality we don't have a clear boundary between clinicians and researcher, because most of the time the author of the paper in the osteopathic field are also clinicians. We have, I think, a few researchers that are pure researcher. So in reality, I didn't really identify why we have that kind of problem, the difficulty to communicate between clinicians and researcher. Maybe we have to move on with continual progressive training with mentorship about how to increase, how to implement science in clinical practice. So rather than teach how to do research, maybe we have to go a little bit slowly and do some mentorship or some postgraduate courses to teach how to use research results in clinical practice. And this is on one end. On the other hand, on the end of the researcher, maybe we have to remember.
E pronto, foi esta a nossa conversa com o Christian Lunghi, espero que tenham gostado. Temos aqui, acho que foi uma conversa bastante produtiva, temos muito food for thought. Infelizmente a ligação não estava muito bem, agora na parte final a ligação, a conexão à internet do Christian Lunghi também tem sofrido aqui algumas medidas de mitigação, assim como a minha, mas felizmente foi só na reta final. E eu consegui falar com o Christian depois e no fundo ele estava mesmo na reta final da sua resposta, em que eu perguntei se no fundo aquilo que é a experiência clínica e a prática clínica não deve orientar também aquilo que é feito em termos de áreas de investigação e áreas de interesse de investigação. E isto leva a um debate que também tem sido feito, mesmo na área da fisioterapia, bastante interessante, sobre aquilo que é a pirâmide da evidência científica e, no fundo, aquilo que está no fim da pirâmide da evidência científica, que são os case studies, não é? Os casos de estudo, mas que também os casos de estudo, às vezes pela importância que têm, pelos fenómenos que acontecem, que deviam ser melhor estudados e melhor entendidos, no fundo, os case studies também deviam orientar aquilo que é feito em termos de investigação. E, no fundo, era esta a pergunta, se os clínicos, no fundo, não deveriam ter também uma palavra a dizer de acordo com a sua experiência e com a evidência dos case studies, no fundo também participar e orientar naquilo que é feito também em termos de investigação e não só ao contrário. Como dizia eu, e o Christian também concordou, há uma espécie de gap, ou um gap aparente entre aquilo que é a área da investigação e a área académica para depois aquilo que é aplicável ou aplicado ou entendido pelos clínicos. Bom, esperamos ver o Christian Lunghi este ano também. Estamos sempre aqui limitados com o que vai acontecer na nossa sociedade, mas esperamos ver o Christian Lunghi com uma formação que tem bastante interessante, que se chama Cuidados Osteopáticos Adaptados à Prática Clínica, onde exatamente inclui todos estes modelos, estas abordagens e estas novas ciências e aquilo que a forma como se podem aplicar também à prática clínica osteopática como profissionais de saúde e profissionais em que ainda continuam com um modelo que é centrado na pessoa, talvez agora mais do que nunca se venha a discutir. A osteopatia teve uma evolução em que de alguma forma acabamos por nos centrar muito em componentes mecânicas e disfuncionais, e hoje em dia está a ser posto em causa largamente, muito fruto daqueles que são, no fundo, os investigadores da área. Mas o Christian, então, inclui aqui os 5 modelos osteopáticos nesta prática clínica e fala sobre estes temas que falámos nesta pequena conversa. A próxima Osteotalk vai ser com a delegação portuguesa do COM, o Center for Osteopathic Medicine Collaboration, tem uma delegação em Portugal há relativamente pouco tempo, do qual eu tive o prazer de também ser convidado pelo Alexandre Nunes para pertencer a esta delegação da COM Portugal, e portanto vou falar com os meus colegas e os vossos colegas Alexandre Nunes, Rui Santiago e João Moita, todos osteopatas e investigadores, e agora os mais recentes membros do COM na delegação portuguesa. Uma conversa que também promete ser bastante interessante. Pronto, vejo-vos na próxima vez e espero que tenham gostado.